Well, yeah, thank you so much for having me tonight. My name is Rick Leinbach, and I grew up in Winston-Salem, just right down the street. I went to med school over at Wake Forest, and now I'm practicing in High Point. I've been here, it'll be 6 years this summer, and I've got a lovely wife, Leslie, and 3 daughters, and we are really happy to be here in High Point. And I'm hoping to give you some information over the next little while about allergy, allergic rhinitis, and how to manage it, and specifically talk about allergy vaccine and immunotherapy. So, over the next little while, we'll talk about what allergy is, what causes it, how do you diagnose it, and how do you treat it, and specifically go into more detail about immunotherapy or allergy vaccine. And talk about specifically a way that we treated it at High Point Ear, Nose, and Throat, applying the vaccine in the mouth, in the floor of the mouth, where it's absorbed and has a good effect to help patients with their allergies. So why is an ear, nose, and throat doctor, why is he or she concerned about allergy? Well, number one is allergy is very common. It affects 20 to 30% of the population. The impact on daily life cannot be underestimated. Some patients find allergic rhinitis to be just as debilitating and as intrusive as severe asthma. And asthma and allergy kind of go hand in hand. There's an association between those. And it's been reported that employees with untreated allergies are 10% less productive than coworkers without allergies. Number two, it can cause symptoms in the ear, nose, and throat. So, a patient might come in with a complaint of a stopped up ear or fullness in the ear, and they have a middle ear effusion or fluid in the ear, and then you want to look for the underlying problem, which could be allergy. It could cause things like chronic sinus disease or chronic sinusitis, which is a swelling in the lining of the nose, the membranes in the nose and the sinuses, causing blockage, where the underlying problem could be allergy. And then it allows us to provide complete medical and surgical care. Occasionally patients come in and they don't respond to medical treatment, and you have to do some surgery, for example, placing a tympanostomy tube in the ear to drain the fluid, or opening the sinuses to allow the sinuses to heal and drain properly. So what is allergy? What is allergic rhinitis? Allergic rhinitis is a hypersensitivity of the immune system that causes damage to the host. It is an inflammation to the nasal mucosal lining caused by an exaggerated hypersensitivity to allergens that's IgE mediated, and we can talk about that. I mean, that IgE is just an antibody, and so everybody has a friend or a family member that maybe has come in contact with tree pollen in the spring or grass pollen in the summer, and develop symptoms of sneezing, watery nose, stuffy nose, and that's what allergy is. Not to dwell on the immunology of allergy, I just thought this was a nice cartoon to show. So what happens is, to become allergic to something, you need to be exposed to that something. So, in the spring, we're all exposed to tree pollen. The lining of our nose will take up the allergen, and then it eventually gets transported to a cell called a B cell. Now, a B cell is the only cell in the body that can make antibodies. So that cell will start making antibodies called IgE, and those antibodies eventually get attached to this cell up in the top called the mast cell. And then later, when you're exposed to tree pollen a second or a third time, the allergen can bind to those antibodies called IgE, and it basically tells the cell to kind of fall apart or degranulate. And that's when the histamine is released and all these other mediators that cause all these problems with leakiness to vessels in the lining of the nose, the watery drainage, the swelling, the itchy eyes, the sneezing, and that type of thing. And the most common allergens are, as you know, dust mites, pet dander, cockroach molds, pollens. And so this is just another slide that talks about those mast cells that are kind of coated with IgE that's just sticking out all over the place. The allergen will come and attach to IgE, the mast cell will fall apart, and then you get the whole cascade of problems with allergic rhinitis. So, understanding the function of the nose is important to understand allergy. Basically, the nose is a filter. It filters the air that we breathe. And as you go along in life, there's going to be mold in the air, there's going to be dust, there's going to be pollen, and your nose filters that before the air gets down into your lower airway. It also humidifies the air, it warms the air that we breathe. And how is this accomplished? It's accomplished by a very large surface area with tissue in the side of the nose here on either side called turbinate tissue. So you have a very large surface area to allow the air to contact the lining of the nose. The nose and the sinuses also make mucus. As you go through life, sometimes you make a little too much mucus, and that can be a problem. That can be something called vasomotor rhinitis. And the lining of the nose is pretty amazing. The little cells that line the nose have little microscopic hairs called cilia, and they're amazing because they all beat in a very coordinated fashion, moving the mucus to the back of the nose where you can swallow it and get rid of it. And irritants, for example, smoke, can cause short-term rhinitis and can actually slow the movement of that mucus. And so the cilia just don't work as well to move that mucus around, and then you could develop a sinus infection. This is just a cartoon of the paranasal sinuses. They're hollow spaces around the nose. And we typically examine the sinuses with an endoscope or a telescope, and that's what this picture shows. A way to look in the sinuses without really causing any damage. If allergy is untreated, you could end up with something called chronic sinusitis, where this is a CT scan of a patient where you can see the eyes and the brain, and then the sinuses are between the eyes and below the eyes, and you see a lot of gray. Gray on a CT scan means inflammation. Really, the sinuses are air-filled, so they should be black. Black means air. Gray means inflammation. So this patient has a little bit too much gray, and there's some blockage to the sinuses, and they're just not healthy. So whenever a patient comes in, the first thing you want to do is sit down and take a complete history. You want to talk about the timing. Is your problem seasonal? Does it occur in the spring? Typically the spring is going to be the worst season because, as we know, all the trees are pollinating. Your car is just covered with the yellow pollen. And so most patients have the worst time in the spring, followed by the grass in the summer, and then later in the fall where the weeds and the ragweed and that type of thing. You want to take an environmental history. You want to ask, well, do you have a cat that triggers the problem, or a dog? Have you been exposed to any molds? Family history is important. Allergy and asthma both run in family, so I always ask, if you have a mom or a dad or a sibling that has allergy problems. And then, the allergic march or the atopic march. Basically, we see some kids and adults that kind of march down the allergy walkway. They'll come in, they may have colic, they may have a milk allergy from IgE, and then they'll develop eczema, they'll develop asthma, they'll develop allergic rhinitis, and this can start from birth all the way up into your teenage years. So you can really see how untreated allergy can have a lifelong implications on the patient's quality of life. You know, I won't go over all the signs and symptoms because you know we know them. It's sneezing, itchy eyes, itchy nose, watery drainage from the nose. On exam, basically, when you look in somebody's nose and you examine the lining of the nose, sometimes it'll look pale, boggy, edematous, swollen. It'll look pale, sometimes almost blue. You can see a kind of a blue color. And so after you do a history and a complete physical, you know, sometimes we'll actually go in and recommend allergy testing. Really, the goal of allergy testing is to identify antigens to which patients are symptomatically reactive and to quantify the sensitivity. And basically that means we're trying to figure out what a patient is allergic to so we can recommend, number one, environmental controls. The best way to treat an allergy is to try to avoid what you're allergic to. So you can, if you know what a patient's allergic to, you can recommend better control of the environment. You know, maybe keeping your cat out of the bedroom. If you have a dust mite allergy, you can use special covers for your mattress or your pillowcase, that type of thing. And then to quantify the sensitivity, you want to get an idea how allergic someone is. You know, are they extremely allergic or not very allergic? There's different acceptable techniques. Basically, there's two major techniques for testing for allergy. There's skin testing, and then there's blood testing, where we check the serum for IgE. And we tend to get a little more information from the skin testing. So typically we'll do skin testing. In smaller children who can't tolerate all the pricks on the skin, we'll send them down to the lab and draw blood. You know, these are some of the allergens we test. Commonly cat, dog, cockroach, mold. I'll just let you read through these. And it, you know, it depends on the panel you choose, and it depends on your degree, your suspicion for how, you know, the patient, whether they have allergies or not, how many you start with. And this is how we do our skin testing. I just wanted to kind of go over how we do allergy testing at High Point Ear, Nose, and Throat. We use a little test called a multi-test, and it's a prick test or a scratch test. So what you do is you order your extract, these are all the different allergen extracts. We use a company called ALK-Abea, and you order all your, you know, whatever you need, your pollens, your grasses, and then you fill up these little wells with the different extracts, and then you apply the multi-test device to the forearm, and it causes like a little irritation to the skin and a little scratch. And then basically you wait 15-20 minutes to see if there's a response, a wheeling response. And you're going to compare that to histamine, which is your positive control, and glycerin, which is your negative control. And then so these are some wheeling responses, and you can see these are quite severe. And if you apply the multi-test, do the prick testing, and the wheels are greater than 9 millimeters, you know, very, very large, then basically you can stop, and you know the patient's very allergic to that particular allergen. If the wheel is not greater than 9 millimeters, then you can follow things up with a little intradermal testing to the upper arm, where we actually inject the allergen below the skin. And this is Betty. She's in the audience. This is our allergy nurse. So how do you treat allergy? Well, number one, we talked about environmental controls, controlling your environment. There's a whole host of medications that help. Steroids are very strong anti-inflammatory drugs. You can take them orally, or you can spray them into the nose topically. And we use a lot of nasal steroids. I'm sure you've heard of Nasonex, Nasacort, Flonase, and antihistamines are very common. Singulair is another kind of class of medication. It's called a leukotriene inhibitor, and that's a whole another medication that does quite well with allergy. It also can be used to treat asthma. And then sometimes we use systemic steroids, which is basically prednisone, where you take a pill or you have an injection if you're having an allergy flare-up. One thing people might not think about is nasal sinus irrigations. Just washing your nose with salt water on a daily or a twice daily basis helps things quite a bit. We talked before, the nose is a filter. It's filtering the air, but you can't really remove that filter and change it like you can in your car. So just washing it out once or twice a day with some saline it really does wonders. And we have a little kit in our office. You can find this really anywhere. It's called Neomed Sinus Rinse, where you just mix the little salt packet with warm, clean water and just wash your nose. And we also have a little recipe to let patients know how to make their own salt solution. So this is kind of a traditional model or algorithm for treating patients with allergic rhinitis. They come in, they have signs and symptoms of allergy. You might offer them a nasal steroid. If they do better, then maybe you're done. If they don't do better, then maybe go on and do some allergy testing. And if the allergy testing is positive, then think about immunotherapy, which is allergy vaccine, which we'll talk about a little bit later on. So this is kind of a traditional model. And later on, I'll tell you about kind of a newer way to think, which I tend to think more about treating patients with immunotherapy earlier, because we found that it works really well. So for the remainder of the talk, we'll talk a little bit about immunotherapy or allergy vaccine. And so what is a vaccine, or what is immunotherapy? It's basically a medical procedure that uses controlled exposure to known allergens to reduce the severity of the disease. So just like any vaccine, you're giving a patient a little bit of Timothy grass or pine tree pollen over a long period of time, and eventually it's going to make some changes to the immune system so you're not quite as reactive to that substance in the future. There are two major routes of delivery. I'd say the most common way to deliver the vaccine is by injecting it into the skin, and that's called subcutaneous immunotherapy. And then sublingual immunotherapy, which we'll kind of talk about the rest of the talk tonight, has kind of taken off and gained popularity in the last, say, 10 years or so. And that is applying the vaccine in the mouth below the tongue, in the lining of the mouth, the mucosa of the mouth. So we'll kind of touch on how sublingual immunotherapy works, and what kind of changes take place in your immune system, and then some dosing and some practical issues concerning sublingual. So what is sublingual immunotherapy? It's the application of FDA-approved allergens to the sublingual mucosa rather than injecting it into the below the skin. And so I showed you before the pictures of all the extracts, and basically what we do is we mix our vaccine in our office, and then we put the vaccine in a small vial, and the patient just doses themselves at home. They'll just go ahead and give a dose of the vaccine intraorally at home. So the idea for sublingual immunotherapy really got going back in the late 1980s. in England after injection immunotherapy was practically banned in England because of some deaths that were linked to injection immunotherapy, subcutaneous immunotherapy. So there was some motivation to develop an alternative route for the administration of immunotherapy with a better safety as compared to injection. And that's really what got us motivated at High Point ENT was one particular patient who was an employee at our office and still works with us, who was on immunotherapy, on shots, allergy shots, and just really could not move up to the highest concentration. The way allergy shots work is you start patients on a dose they can tolerate, a low dose, and then over the course of several months to years, you move them up to a higher maintenance dose. And this particular patient, every time she moved up to the more concentrated vial, she would have local reactions to the skin, she would, her asthma would flare up, and she just really couldn't tolerate it. So that got us thinking about finding a safer way to offer immunotherapy. And so we began to look more closely at sublingual as an option. It's been used in Europe for over 20 years. It's gained interest in the United States in the last 10 years. It's accepted by the World Health Organization. It's taught by our governing academy, which is the American Academy of Otolaryngology Allergy, or ENT allergy. And it's taught in residency programs. So why sublingual? Well, because it's safe and it's easy. And you get to avoid needles. You don't have to go to the doctor and get a shot every week. And there's a shorter escalation period. We were talking about earlier where typically you'll start patients on a low dose and move them to a higher dose. And with sublingual, that escalation period takes about 9 weeks. So I'll show you here just a... We'll show you our protocol in just a few slides, but so it takes 3 vials over 9 weeks. So you start with 1 vial and you use that for 3 weeks, and then you go to your next vial for 3 weeks, and then you go to your 3rd vial for 3 weeks, and then you finally get to your maintenance, and that's what you use for the rest of the course of your therapy. And some people ask, well, how long do you treat someone? And really duration of therapy is kind of being worked out. If you ask an allergist, I'd say you'd probably get an answer about 3 years is typically the amount of time you want to try somebody on immunotherapy and see if they respond. So it is a big commitment to a patient. You got to say, well, you haven't responded to Flonase and Zyrtec, and you want to try this. You're really going to have to commit to this for a good period of time. So, how does it work? Well, the antigens being in contact with the oral mucosa is very important. So, like I said before, we have the patient apply the vaccine to the floor of the mouth and hold it for 2 minutes. We ask them to hold it in their mouth for 2 minutes and then swallow it. And so it's captured by cells in the floor of the mouth called dendritic cells, and they mature, and then they migrate into the lymph nodes in the neck. Your lymph nodes, obviously you've got a lot of lymph nodes in your neck, and then they have an effect on your immune system, on different cells in the body. And I won't dwell on the immunology, but we talked about the IgE before, being bound to those mast cells, so it has been shown to decrease the IgE, which is what you want. And then it has been shown to increase IgG, which can be antibodies that block allergic reactions. So it has been shown to modulate your immune system over time. So does it work? If you read, if you go Google sublingual immunotherapy, there's going to be many articles that have been done on sublingual, and they're all really good studies. They're all the randomized controlled trials that you hear about, where you have a one group that takes the therapy and one group that takes maybe a placebo therapy. So just to pick a couple big studies that looked at the efficacy, Brian Leatherman, he's an ENT allergist, so he's like me, he's an otolaryngologist. He looked at 36 studies, and these were all really good studies, randomized controlled, double-blinded trials. And out of the 36, he found 30 found sublingual to be effective. And that was back in 2007. And Linda Cox, now she's on the medical side of allergy, you know, medical general allergist. And she looked at 47 studies. And like I said, these were all either double-blinded, placebo-controlled trials or randomized controlled trials. And she found that 65% of the studies showed some evidence of efficacy. But what are some criticisms? A lot of these studies were done in Europe. Like I said before, this really got going in the 80s back in Europe. So a lot of these studies are European studies. And so sometimes it's difficult to translate that into U.S. dosing. A lot of these studies just looked at one antigen, for example, like tree pollen. And so more studies are needed, is the bottom line. Just to go over our escalation scheme, this is what we show patients where we talked about they get vial 1 and they use that for 3 weeks and they increase the number of drops they apply to the floor of the mouth each week. So they'll put 1 drop daily for 7 days and then 2 drops daily for 7 days and then 3 drops. And then they go to vial 2. And then they kind of work their way up until they get to their maintenance vial. And the maintenance vial, we mix it in such a way with enough volume where it lasts about 3 to 4 months. So it's going to last them quite a long period of time. So this is what our vials look like, where they're easy to administer. You just, 1 squirt is 1 drop. So it's easy for patients to use. And we mix it in a diluent called glycerin, 50% glycerin. Glycerin's like a preservative, so it's going to stabilize all of those allergens. And so it makes it very stable, so you don't have to refrigerate it, number one, so you can take it on vacation with you. In subcutaneous or injection immunotherapy, you can't quite use as much glycerin because glycerin hurts when you inject it. So the vaccine is not quite as stable with subcutaneous immunotherapy, where you have to refrigerate it and you have to kind of take care of it a little more closely. You do once daily dosing as compared to subcutaneous, where it's about once a week. So you do have to dose yourself daily. So who do you recommend this to? Well, to start immunotherapy, number one, you have to be allergy tested. So with either skin testing or blood testing. And then patients with significant symptoms, and then attempts to avoid allergens fail or impractical. Like I said before, the best way to treat allergy is controlling your environment, trying to avoid what you're allergic to. But in the spring, that's not really practical. I mean, everybody's got to go outside. There's tree pollen everywhere. In the summer, people are mowing their grass. I mean, you're going to get exposed. So it's not really practical for some seasonal allergens. And then, like I said, the patient needs to be motivated and compliant with treatment. You have to kind of get them to buy into, it's going to take a while. It might take 6 months before you notice a benefit, and then you need to be on therapy for, say, 2 to 3 years. So safety. There's been over 1 million doses of sublingual immunotherapy, and there's been no fatalities, which I think is wonderful. on the subcutaneous side, it is very safe, and we still offer it and recommend it. But there's just a higher risk of anaphylaxis, having a problem, and there have been reported deaths with subcutaneous immunotherapy from anaphylaxis. You know, we've been offering sublingual now at Hypoin ENT for about 5 or 6 years, and you know, very few. We haven't had any major reactions to the vaccine. Minor complaints from patients include maybe some itchiness in the back of their throat, some irritation to the lips, and that's more common during escalation when we're moving them up to the highest concentration. And once you get a patient up to their maintenance, they're pretty good to go, where they don't have a lot of this oral symptoms that can develop. Okay, so you know, we always have Betty sit down with the patients and give them a safety talk about the possible side effects of sublingual before they start therapy. We always have them carry or have available an EpiPen, an epinephrine pen, and when children are dosing themselves, we always require their parents to be there with them when they dose their vaccine. The cost of therapy. You know, sublingual is taken off in the last 10 years. It's offered at a lot of different tertiary care centers like the Medical University of South Carolina in Charleston, Yale, University of Texas Southwestern, all over the country. But unfortunately, we don't have a CPT code, a procedural code to bill insurance. So it's an out-of-pocket expense. So we try to keep the cost at a level where it's about the same as a patient that would have to come in and have their shot at the office on a weekly basis. So our build-up vials are $75, and then once you get to maintenance, it's a $90 for the vial. And so it's about $30 a month once you get up to maintenance. And compare that to, you know, having to take off from work, come in, get your allergy shot, perhaps having a copay to pay as well. It's about the same. And we're working to get a CPT code. We're actually working with our general medical allergist colleagues to apply for one, and hopefully that'll be something that we'll get in the next few years. So this is kind of a new model or a new algorithm. I actually got this from Dr. Schlosser down at in Charleston, Medical University of South Carolina, where he kind of thinks, and I kind of think in this way too, where a patient comes in with symptoms, maybe go right to allergy testing. And if they're negative, maybe consider another diagnosis. Or if they're positive, start them on sublingual. If they show improvement, then you're done. If there's no improvement, then maybe add medical therapy with nasal steroids or antihistamine. So it's kind of a different way to think about things. So at Hypoin ENT, we've got close to 400 allergy patients that we're treating currently. The majority of those are subcutaneous, around 300. We have about 60 to 70 sublingual patients that we're treating right now. We've had very few local symptoms, and the majority of patients have moved up to maintenance without difficulty, and I would say are benefiting from the therapy. So in conclusion, I'll wrap this up, that you know, there's been an increase in the prevalence of atopic disease or allergy in the U.S. over the last few years. We don't really know why that's occurring, but we know that allergy causes significant morbidity, and many of these individuals are undertreated, so possibly sublingual immunotherapy could kind of fill in the gap and take care of the patients that might go untreated. And that's it. And I'd be happy to take any questions. Thank you so much for allowing me to come tonight.
This group usually has questions. Anybody have questions?
Yeah.
Do allergies, do people get, are they born with allergies or do they become, I mean, it seems like people get allergic at all different times in their life, but I wonder how does that happen?
Yeah, you can really develop allergies at any time in your life. You really just have to be exposed to the allergen repeatedly, and then you can become sensitized to it. There is a genetic predisposition, so genetics play a role. If you always ask does your mom and dad, siblings have allergy? So if you're genetically predisposed and you're exposed to the right allergen, you'll probably develop an allergy to it.
Is there any surgery to help your sinuses drain better?
Surgery? Yes, there is. The CT scan that I showed, that patient had what we call chronic sinusitis, and that's kind of a whole nother talk, and that is really not well understood, to be honest with you. Some people develop chronic sinusitis where the lining of the sinuses in the nose swells and there's blockage. And there is ways to go in and just take out a small amount of tissue and to create small windows in the cheek sinuses and help drain the ethmoid sinuses between the nose. And that surgery is really not very invasive surgery. It's fairly minimally invasive. It's outpatient. So yeah, there are ways to do that. So.
I'm not sure if I had the right terminology, but if you have a deviated septum,
Septum, yeah.
Okay. Does that leave you more vulnerable to or predisposed to allergies?
No, I'd probably say no. So the nasal septum is the midline divider in the nose. It's made of cartilage, and as you go back, it kind of turns into a plate of bone. And if you've got a deviated septum, you can have nasal obstruction, where you can't breathe through your nose very well. It can also kind of predispose some patients to nosebleeds. Like, this is kind of the time of the year where we're seeing a lot of nosebleeds because the air is dry. And I saw a patient today whose septum was deviated, and just the way the air flows through the nose can have a drying effect. It can dry out the nose and cause a nosebleed. So, yeah.
In the 1980s, I was having sinus problems. I had a Caldwell Luck procedure done.
Mm-hmm.
Now it's like over 20 years later, and I'm developing chronic sinusitis again. The Caldwell Luck surgery helped,
Mm-hmm.
but I am now developing chronic sinusitis again. Glad to hear about a more invasive procedure, certainly. What I'm saying that to ask, does the bones grow back or anything to get where I'm not draining now like?
There can be new blockages that develop. There's some changes to the bones that line the sinuses. Yes, they can thicken from chronic infection. I don't know if everybody heard, but she had a Caldwell Luck procedure, which is a more aggressive type sinus procedure that is not really used as commonly today, where you lift the gum up and you actually make an incision in the face of the cheek sinus, and create a little hole, and where you can clean out the cheek sinuses from below the lip. And there could be some blockages in other parts of your sinuses. That's a possibility. Yeah. They sure can. Cough is a whole nother huge topic that's very complicated sometimes, but my top three for cough are postnasal drip, acid reflux, or asthma. You know, those are kind of my top three. If those, you pick up about 80–90% of patients with those three, and then you can think of other things like maybe a medication or, you know, that type of thing.
Are some antihistamines better than others? Because I know someone who uses a lot of Claritin. Is it liquid Claritin?
Uh-huh.
So what do you think of that? Is that better than some of the others?
You know, okay, so Benadryl is kind of an older antihistamine, and it's sedating. You know, a lot of people will take it at night and they'll make them fall asleep. And then they had kind of newer generation, second generation, third generation antihistamines that were supposed to be non-sedating, like Claritin, like Allegra. It's funny, you know, sometimes we'll try patients on one antihistamine, they don't really have a good effect, we'll try them on another. They're all fairly similar, but the Claritin's one of them that I like to use.
Regarding preventive measures, how do you feel about high-dollar air filters?
Like for your house? Well, if your symptoms are severe, and yeah, I think that's a good idea to try to look at your house and take away some of the allergens that are there. You know, some people will go to maybe a hardwood floor and, you know, take away some of the carpeting and but yeah, I think that helps people.
Can I ask you, I've got about, I never had it before, I guess I've had some sinus drainage and my left ear seems a little blocked. I'm wondering, should I go see the doctor? So will it go away in 2 or 3 days or something like that?
Well, if it's short term, you could try some medications to treat it. Have you tried any medication?
I don't really have allergies. So
Yeah,
sinus
like Sudafed, if you can tolerate. Some patients can't take Sudafed because it affects blood pressure. But if your blood pressure is under good control and you're able to take Sudafed, you could try that for a few days. That really helps.
Would Benadryl help? I already have some of that.
Yeah, Benadryl, nasal saline washes, thyme. You know, I'd probably give it another week to 2 weeks. If it's still stopped up, then you probably need to be seen. Yeah.
We really appreciate your being with us tonight, and
Well,
this is just a little token.
Oh,
of
look at that. Thank you.
appreciation.
Appreciate that.
If anybody has further questions, you want to stay?
Yeah, I had a question. Is it better to start with the prevention before you really get stopped up, or does it matter?
Well, if you know your bad season, like if you know spring is bad, it is better to get started earlier on medical therapy, on medications.
Because I had the shots and was allergic to those.
To the shots, really.
Yeah.
But you know, a lot of patients have been dealing with this problem for a long time, so they kind of know themselves, and they know when their bad season is. And yeah, starting you know, a nasal steroid antihistamine a month or so before your bad season is a good idea.
Dr. Leinbach, if a patient wants to see you, do they need to go through their primary care physician, or can they make an appointment with your office directly?
They can make an appointment with our office directly. Yeah, we see new patients all the time. So,
Unless their insurance requires referral.
okay. I got a red hot mama that's keeping me in line here.
Insurance will require referrals for specialists, but if your insurance does not require it, then we don't require it.
Dr. Leinbach, sometimes I have these, it's an odor, but it don't last. It may last for maybe like in the morning time, and then it goes away.
An odor, I know that's a tough. You know, sometimes I get complaints, or I get, you know, patients reporting that, and that's a hard thing sometimes to figure that one out. you want to rule out infection. Obviously, you can get odor from infection. I really like the sinus rinse, the nail meds. You could probably just maybe rinse your nose, in the morning. It'd be a good time to do it.